This is the Eat Well, Think Well, Live Well podcast. I'm Lisa Salisbury, and this is episode 41, Navigating Perimenopause and Menopause with Hormone Replacement Therapy and How It Affects Weight Loss with Dr. David Rosensweet. Now, before you younger listeners tune out thinking that this isn't affecting you, you're going to learn from Dr. Rosensweet that once you reach your 30s, your hormones are declining and you are in perimenopause, as this is the time preceding menopause. So just by virtue of your age, once you reach the 30s, you may not be having classic symptoms, but things that you may not attribute to menopause or perimenopause rather are actually occurring because of the decline in hormones. I loved editing this episode and listening and learning from Dr. Rosensweet again. We recorded this about a month ago, and I've been dying to put it out. I was saving it to do a whole series on menopause, but those other interviews just haven't happened yet. So I will put those out when we get them scheduled and keep talking about these things that are affecting us in this perimenopause time and how to combat them. So please feel free to send me any questions about this, and I will be sure to ask the next expert I have on this topic. I will tell you too that after doing this interview, I did ask my regular gynecologist about bioidentical hormone replacement therapy, and she agreed with me and started me on a very tiny dose of topical estrogen. She isn't trained in Dr. Rosensweet's menopause method, but just for those listening wondering when we get to the point in the interview talking about HRT and what doctors will prescribe it, you totally can start with your regular gynecologist and see what she can do for you. It is totally worth an ask. So don't forget also to download Dr. Rosensweet's free book to have a little bit more language around this topic. And that link, of course, is in the show notes. Welcome to Eat Well, Think Well, Live Well, the podcast for women who want to lose weight but are tired of counting and calculating all the food. I'm your host, Lisa Salisbury. I'm a certified health and weight loss coach and life coach, and most importantly, a recovered chronic dieter. I'll teach you to figure out why you are eating when you aren't hungry instead of worrying so much about what you are eating. Welcome back to the Eat Well, Think Well, Live Well podcast. Today, my guest is Dr. David Rosensweet. I'm super excited. He reached out to me and thought that his knowledge about menopause and his expertise was really going to be of value to my audience, and I totally agreed. So we have had a couple of questions recently about menopause, a little bit about perimenopause. So I know this is kind of the age range that my listeners are in. So I'm super excited to have him. I'm going to let him introduce himself, and then we'll jump into our conversation.
I'm a medical doctor. I was traditionally trained. I loved medical school. I love my traditional training. It was like arriving at a temple or a synagogue for me. And then when I left medical school, I started getting interested in things that really related to health and root cause. So I did a lot of work with nutrition and the exposure we have to toxicity and detoxification, with exercise, and with the elephant in most people's room, a dysfunctional response to the stresses of life, because that disrupts the immune system, disrupts the hormonal system. Yeah, we can do fight or flight biology, but it takes a toll on us, because I was really interested in what's getting my patients ill and how do we do well. And then about 30 years ago, a patient of mine that I knew really well stormed into my office. She was in her mid-40s. She did not have an appointment. She flew open my examining room door, my consultation room door, and she told me, "Look, I'm going crazy, and don't pretend you know. I'm telling you, I'm going crazy. This is big stuff." And serendipitously, so to speak, although I don't think life works like that, I had been speaking to a world expert on progesterone, and I gave her progesterone. She was in her mid-40s. And 3 weeks later, I got a letter from her saying, "My God, this stuff is miraculous. I mean, I feel so much better." That was pretty dramatic. You don't often, people, by the time they've gotten ill, it's often a slow-moving process to do the various changes we need to do. And we don't necessarily see these tremendously dramatic results. Well, these were tremendously dramatic. And before I knew it, I was seeing a lot of women in the perimenopause and menopause. And then I decided to specialize in it. For the last 30 years, I've really headed towards total specialization in it. because it's an amazing thing. It happens to 100% of men and women. We start out at the age of 20, and that's when we're putting out our peak ovarian or testicular hormones.
Mm-hmm.
And then it's declined from that moment on. And in the 30s, a lot of women don't really feel that decline, but it's taking place. And some women do. Their periods start getting irregular, and they start getting return of PMS. They start not sleeping as well, mood issues, because they're losing their ovarian hormones.
Mm-hmm.
And then comes the magic day when the periods cease entirely, and there's almost a full loss of the most powerful biochemicals in a woman's body. Amongst them, there's other powerful biochemicals of that magnitude: thyroid hormone, some adrenal hormones, but these ovarian hormones, estrogen, progesterone, a woman's body treasures these. And without them, the declines that you see that ultimately result in assisted living facilities, nursing homes, adult diapers, why do people wind up there? And most women wind up there because of the loss of ovarian hormones,
Hmm.
the loss of muscle and bones.
Big cause of like generalized aging, then? Is that what you're
Well,
saying?
there's very specific declines because these
Mm-hmm.
hormones are so important. Yeah, we could say generalized aging, but specifically there's loss of bones, loss of muscle, loss of cognitive ability, loss of energy, loss of libido, loss of vagina, loss of bladder control, loss of arterial protection that estrogen confers, vulnerability to heart attack and stroke. These all derive primarily from the loss of the ovarian hormones. It's a big deal.
Yeah, yeah. I'm a big fan of I've said this phrase on the podcast before, and I got it from someone else. I don't even remember who, but just the idea of making our health span match our lifespan. And so this is really critical here because I don't just want to live to 100. I want to live to 100 and be completely functional and still be driving and getting up and down off the floor in my 90s. I really want to be as healthy as possible. Yes, I'm going to have beautiful wrinkles, and yes, I'm going to have gray hair, and that is all completely fine with me. I just want to be able to get my own groceries and not worry that I'm going to fall down. And so this is really critical then to pay attention to those female hormones
Yeah.
when we start having these symptoms. And we could go over things like what are like menopause and perimenopause symptoms. I think you kind of covered some of them. I recently had, well, let me just be honest. I have a Mirena IUD, and I know that that's some people are like, it's not a problem at all. Other people are like, rip that thing out. I don't know how you feel about that, and my listeners can decide what they want. But in any case, very, very, very light periods because of it. But I've noticed even though I have that in, it's getting more irregular. And all of a sudden, like I have like this tiny period, and then 10 days later, I'm like gushing for the first time, like since I've even been on it. And I'm like, okay, hello, perimenopause. This morning, I woke up in a complete sweat. I was like, why are my pajamas so wet this morning? That's fun. So it's just these tiny little things. I think most women probably are pretty aware. But what do you think are symptoms that we aren't aware? Like we know irregular periods, night sweats. Most women know this. What are some things that are happening that are perimenopause that women don't realize or don't attribute to that and are maybe signals for them to start getting help?
Well, it's a great question because although 75% of women have really dramatic symptoms, such as the ones you just named, welcome to perimenopause. Year in. 25% of women don't have symptoms, and they look around, they say, what's this big deal about menopause? It's my menopause is easy. Yet for 100% of women, as estrogens decline, you start losing bone. We don't feel that.
Mm.
You start losing cognitive function. You start having memory issues and often the ability to think clearly. You start having mood issues from the loss of these hormones. I've heard women tell me that they didn't even realize it until they started getting treated with testosterone, that they lost some core drive there and decision-making power.
Mm.
Because testosterone is not a male hormone. That's very, very incorrect. Women have twice as much testosterone as they have estradiol, the most potent estrogen. So mood, sleep, a natural calmness can be replaced by a subtle anxiety. It's not 100% of the day, but there can be a declining mood and the ability to sleep deeply, or you can wake up in the middle of the night and be in a sweat. Now, by the time you make it to Sweatsville, you have got major estrogen decline. And the
Okay.
optimal time to address it is now. We love when we're able to interact with a woman who's in the perimenopause. It's the easiest time. It's a more complex time to treat because of the erraticness of the hormonal environment in the perimenopause, but it's the best time of all.
So best to really start treatment when
Now,
we're first seeing signs of
yeah.
perimenopause. Is there a certain age or just watch for symptoms?
Well, it's different woman to woman for a lot of different reasons. Some women start picking up on irregular periods and the kind of symptoms that you're having in their 30s. Well, for sure, here's the benchmark. Your optimal ovarian output took place when you were 20, plus or minus a couple of years, and it gradually declined. So what's the impact of that decline, and when does it lead to really life alerting symptoms? Sometimes it's in the 30s. If a woman is used to clockwork periods, and she realizes she's not clockwork anymore, and that there's even some cycles where she gets breast tenderness or irritable or PMS. Oops, she stopped ovulating that cycle. She didn't ovulate. She didn't put out progesterone, the greatest calmer that exists for women. So the best thing I could offer is, and I believe my team has done this, is that your listeners could receive a free PDF copy of the book we wrote for women. We wrote it for women. It's called Happy, Healthy Hormones. And it describes in significant detail the kind of things to be on the lookout for and how to address it. I think we've really laid down the roadmap, the best way to address this.
And you're a fan of hormone treatment.
Oh, am I?
Yeah, tell us about that. So we're like, okay, it's time to get treatment. It's time to like address this. What is the best treatment?
Well, the things that you focus your professional career on, they all matter. Big
Mhm.
time. Proper nutrition, detoxification, proper exercise, they all matter. But when it comes to hormones, you're going to do one of two things. Those ovaries and those testicles, they do decline, and I've never seen it different. It happens to everybody. For the couple 100,000 years humans have been alive, there was no such thing as menopause.
Because
Women,
we died.
yeah, that's right. Yeah, a little death
Yeah.
therapy took care of that. But when hygiene improves and all the other agriculture improved, nutrition improved, we started living beyond the natural design here.
hmm
And the Chinese figured this out. For over 1,000 years, they had been administering hormones to their aristocracy. What they figured out doing was they sent healthy young women into an outhouse and collected vast amounts of healthy young women urine. And they sent healthy young men into a different outhouse, collected their urine, dried it out, and the aristocracy took the powder that was left behind because they contain hormones.
Hmm.
That was the beginning of bioidentical hormones, same molecule. But in medicine, when something's not working like it used to, you've got two choices. You either figure out some medicine or herbs are medicine, that force the body to react in such a way that you get the desired outcome. So, for example, could you take an herb that would jolt those ovaries back into production? No, it doesn't work. Can you take a variety of herbs? Because people seem to be more friendly to herbs. I certainly I'm a holistic medical doctor. I love herbs for their medicinal use. Could a woman take something that sort of simulated the effects of these powerful biochemicals? Yeah, but it doesn't work. You're going to run across very, very few women who say, oh, yeah, I took this herb, Cohosh or Vitex, and everything returned to normal. These women don't exist out there.
Mm-hmm.
Yeah, ginseng helps. There's things you can do, or we've had this opportunity since the 1980s to take plant-derived, same molecule as produced in the ovary or the testicles. We can take it in topical form. We can rub it onto our skin because that's the healthiest way to take estrogen, is to rub it on your skin. And
So that's
it's,
considered a bioidentical hormone.
yeah, same molecule as the ovary used to
Okay.
put out, same molecule as the testicle used to put out.
And when people say they're on bioidentical hormones for menopause treatment, what hormone is that? What are they taking?
Well, there's a wide variety of beginners treating women in menopause, or very at the other end of the spectrum, experts. Very few experts, a lot of beginners, a few intermediates. And so it depends on the quality of what the woman is receiving. When you get into the compounded bioidentical world, it gets a lot better.
And that's what you do
Yeah.
for your patients. So what do you
Yeah. Because
recommend
we
then that
because we individualize the treatment of every individual woman, because women are so individual, as are men. There's some women who they function beautifully and are very healthy with this level of estrogen. They have periods, or the periods are regular. They're fertile. They can have babies. But there's other women who need 3 times that amount to be healthy, regular
Oh,
periods. So there's a tremendous variance individual woman. So the best approach to this is you individualize the treatment with each individual woman. And you go on a journey to do that.
yeah. That's why people don't say I'm on bioidentical estrogen. They say I'm on bioidentical hormones because it's customized.
Then they get 4. Well, every woman loses all 4:
Okay.
the estrogen family, progesterone, testosterone, and DHEA. They're all coming out of the ovary.
Mm-hmm.
And women lose all of them. Women are in nursing homes. The major reason is the loss of testosterone. You lose muscle.
Which I've always taught is the natural sarcopenia is a natural muscle wasting that happens with age. And I encourage my clients to continue weight training and that sort of thing, lifestyle wise. But we also then need
Right
some of
on.
that testosterone
You do.
to carry on. Okay.
And sarcopenia, there's nothing natural about it. It's just happened.
Right. I just mean like it's kind of like what happens with aging as far as you're not so much doing anything wrong as this is just what happens if
That's
you
right.
don't do anything. If you
That's right.
don't do anything to combat it, that's what will happen. Is that accurate?
That's 100% accurate. As a gerontologist taught us in medical school, sarcopenia is the bane of the elderly.
Mm.
They're all losing muscle. And the ones who aren't losing muscle, sometimes you can really achieve decent things with vigorous, robust exercise programs.
Mm-hmm.
That's rare. You need the combination of a vigorous or decent or humane exercise program. You can't get away without it. And the hormones. You need the androgens. You need testosterone and DHA. That combination will give you what you want. It is to be alive and active, and God, you might even have libido. You might even.
What?
I mean,
That's crazy.
I know a patient who's 81. He and his partner are having the most intense orgasms they've ever had in their lives. A lot of it is because the great personal growth that occurred that allows them to get more intimate and close on every
Mm-hmm.
level. And a lot of it is the bioidentical hormones that
Hmm.
they've just kept up with, not youthful levels. They're not taking youthful levels.
So, how does that work with long term use then? If we are getting on those bioidentical hormones at the start of perimenopause, so sometime for some women in their 30s, typically probably more in the 40s, then do we plan to be on those adjusted every so often for the rest of our lives, or how does that work?
Yeah. The answer is yes.
Yes. Okay. Yep.
Or
Just
another way to find out is not to interview me as a doctor, because I've got a pony in the race here, right? Strongly opinionated. Talk to a woman who's been on bioidenticals for a while and ask her how much she'd love to stop taking them.
Mm,
Or talk to a man. And for example, I take my testosterone every day, and I wouldn't dream of stopping it for every
mm.
single day that I'm on this planet.
Okay.
There's no need to stop them. The whole fallacy around stopping occurred by this outrageously odd, crazy, misogynistic human historical event that took place in the early 2000s with the publication of an article, a medical study that scared women into thinking that if I take hormones, I'm going to get breast cancer. I'm going to increase risk for breast cancer. That was never in the study.
I think most women are probably aware of it and
Yeah.
wondering, like, why are we talking about these? Because it's been shown that, like, that's not safe. So, yeah, please get into that.
Yeah. It poisoned the medical community. It poisoned women all over the world. And even in the original article that came out, the press grabbed something out of that article and failed to see what the science actually said in the article.
Mm,
There was 2 hormones being tested, pregnant mare urine-derived estrogen. And what that study showed is that women who were on pregnant mare urine-derived estrogen had less incidence of breast cancer, heart attack, and stroke than women who went untreated. That was right in the study.
and yet the opposite is what the press published?
That's right. It was because there was this other arm of the study in which women were
Mm,
given something called Prem-Pro. That's a combination of Premarin and something
mhm.
like in your Mirena IUD. It's a progestin, and it did not have a scientifically proven increased risk. In fact, it said the 1.26 relative risk was statistically insignificant. That's what it said in the study. In medicine, that means don't draw any conclusions about this, folks. There is no medical significance of it proven. And that original article, its authors republished a retraction of that article in 2016. They said after 18 years of follow-up, there is no increased risk. But so few people have heard of that. That means the American public and the providers, they're still working off of false knowledge. But here's the science, and I'm so glad you brought this up. Here's the science. We are all at risk for thousands of diagnoses. A lot of them are not cool. And we're all at risk for hundreds of cancers. And the very factors that you are addressing in your work in helping people with their health are the causes. There are causes of illness. There's causes, and they come down to basically issues of nutrition, issues of toxicity, issues of too little or too much exercise, or issues of a dysfunctional response to the stress of life, a perpetual fight or flight response. Those are the only causes. There aren't other causes. There are some mysteries. There's some people who get ill and they're unexplainable, but those 4 causes that you're addressing are the causes of
Mhm.
all illness, including cancer. And there's hundreds and thousands of indiscretions that people can do over the course of their life of nutrition, toxification, etc. And that causes illness. But at any rate, we're all vulnerable to hundreds of cancers we could have. And as a male, I have especially
Mhm.
increased relative risk for prostate cancer. And there's reasons for that. They're modern reasons. They didn't used to be this way. And women have slightly increased relative risk for getting breast cancer over other cancers. And there's very specific reasons for this, and they're modern reasons that has changed over the course of my medical lifetime. It didn't used to be as prevalent as it is today. However, given all that, and thanks for bearing with me here, but it's such an important topic. Given all that, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. And that is the science. And it's beautifully outlined in my book for women who get my book, chapter 3. I go into it in depth. And then there's a Bible written by an oncologist, a cancer specialist who specialized in breast cancer. And that book's called Estrogen Matters. And I cite that in my book. So if you want to know the science, we're all at risk, but we're at less risk if we're treated with hormones.
So how do we ask for this if our kind of mainstream medical doctors, which I think most people are, that's their first line of defense. They're probably not heading to a functional medicine doctor first or a naturopath that might be able to prescribe these. If we are just using our regular doctors, are they able to prescribe these bioidentical hormones, or do we have to go to some sort of specialist? And the other part of this is, what kind of testing do we need prior to requesting this or saying, hey, I think I need this? I'm a big fan of advocating for yourself. I appreciate those that have, done the education and gone to medical school, and I want their wisdom. But at the same time, I want to advocate. And I think there's a difference between, being a Google doctor and just WebMD everything and saying, hey, I need some help with this. So, you know what I mean?
I love it. This is exactly how I love a discussion like this to take place. You're bringing up the most important questions. Well, traditionally trained medical doctors and nurse practitioners, they can do a tremendous service for us when we catch them in their knowledge base and their expertise. But if you try and take them outside their knowledge base, you're not going to get anywhere. And the whole medical community has been poisoned. Their minds have been poisoned. I use that intense language because it's been so disruptive. They're afraid to treat their patients with hormones because of that 2002 study that got so much press. And so you name the remedy, you got to advocate for yourself. Now, the landscape is changing. This, how I laid down the non-risk, the women who are treated with hormones are at less risk. It's creeping back in, but creeping.
The bioidentical hormones are creeping back in. Is that what you're saying?
No. The knowledge that women are at less risk if they're taking hormones.
So some people are starting to say, hey, we really read the study and that's not really accurate. Okay.
A few. And a few have read Dr. Blooming and Dr. Tavris's book, and they get what the real science is. But it's pretty rare. If I had to guess, I'd say less than 1%, 2% of the world population are really familiar with what the science is. I told you what the science is. I'm going to go farther with the science as a little bit of a distraction. Women who have had breast cancer and have had that breast cancer properly treated, they have an increased relative risk of getting a recurrence over a woman who's never had breast cancer is of getting breast cancer. But women who have had breast cancer, had that breast cancer properly treated, they're at less risk for recurrence if they're treated with hormones than if they're not treated. That's how profound this is. Women who have a special genetic propensity for breast cancer and ovarian cancer, they have something called a BRCA mutation. They have an increased relative risk of getting breast cancer over women who don't have that mutation, but they're at less relative risk for getting breast cancer if they're treated with hormones. And the hormones that have been most studied in this regard are horse urine-derived estrogens or horse urine-derived estrogens coupled with the abnormal molecule that's in the Mirena IUD. God bless IUDs. They're a fantastic tool, that's for sure. And Mirena is very popular and for good reasons. But there are others. The bottom line is a woman has got to, at this day and age, 2023, these very primitive human times, a woman has got to become an advocate for her own self. And here's the only job. The only job. You have to go find a healthcare provider that has gotten education in treating women in menopause. It's not there in our original training. You have to go out of your way to get that training. And you've got to find a provider in your state that really understands the whole of treating women with hormones, and that the woman yourself, you feel comfortable with that provider. That's your only job, really. You can facilitate that job by reading my book, Happy Healthy Hormones, because you'll be more informed. But your main job is to find someone who's saying, I treat women in menopause with compounded bioidentical hormones.
Okay. So those are the words we're looking for. And then they will know what testing to do in order to...
Okay, well, let me answer that.
Okay.
No testing.
No testing.
We test 100% of the woman's hormone levels, but not in the beginning. It's perilous. Like, to test a woman like you would be a mistake, big mistake.
Why is that?
10 years ago, your ovaries were putting out estrogens, for example, in a very predictable, amazingly coordinated way. If this is day one of the cycle, it gradually rises, then it falls, then it rises a little bit and falls again. You have a period once a month. It's just so amazingly astounding, predictable in a healthy woman. It's miraculous. But when the ovary stops putting out the robust levels of estrogen, for example, this holds true for the other hormones too, the brain and the pituitary register that, and they go, where's the sufficient estrogen? We don't have enough here. And so there is a remedy. The pituitary gland can push out some more stimulating hormone to the ovary to get it to wake up a little more. But it only works momentarily. So what happens to a woman in a perimenopause is things get erratic. Oh, you described an erratic cycle thing happening. That's exactly what happens. Your brain registers that you're too low. It puts out a stimulating hormone. You get this high level, but you can't keep it up. So it goes low, stimulate, up and down. So when you test a woman in the perimenopause, you get erratic, unpredictable, and results that aren't useful. How did I learn this? I tested women in the perimenopause, and I remember sitting in front of a patient of mine. She was your age. I'm showing her test results. We use state-of-the-art test results, 24-hour urine hormone testing. And she's having hot flashes, and she's waking up in the middle of the night, and she can't fall back to sleep. I know she's got low estrogen, and I'm showing her that her test shows high estrogens. And I say, well, I definitely want to treat you with estrogens because you're having hot flashes. So I know that you're low in general. You might have been high on that. She looks at me like, oh, what kind of crazy man are you? You're going to give me estrogens when my estrogens are high? So it's perilous to test a woman in the perimenopause, and there's no need to.
Because if you tested her 2 days later, she would show
She
low.
could be super low.
4 days later, she's high again or mid. Like, it's just not... You'd have to test every single day of the month, and that would be cost prohibitive.
Precisely. And what would happen is you would see that she may be high on some days, low on others, but when you add up the total amount of estrogen she's putting out in a month, it's low. And that's why she broke out in a sweat. The general lovely level of estrogen that women thrive on, it's not there anymore. It's low. Now, we test 100% of the women, perimenopause, menopause, but we only do so when we've developed a program where the woman says to me at the 3-month mark, at the 6-month mark, she says, wow, I feel great. I feel really good. I feel like myself again. Well, we confirm that with testing because just alleviating symptoms doesn't work. It's not accurate enough. And 75% of the women who say, wow, we went on this dose determining journey where we started low and gradually increased, and we alleviated my symptoms. I feel so much better now. When we do that, you can get symptom alleviation, but 75% of the women will not have their optimal amount. And we want optimal amount. And we know what those are.
Okay.
For example, on the low end, a woman's got to have enough estrogen to protect her bones and her vagina. And we know what those numbers are. And the high end, we don't want a woman to have too much estrogen, so she's overstimulating her breast glandular tissue and leading to breast density. That's a risk. We don't want to do that. So we know what that wonderful optimal zone is, not too much and not too little. And so even though when we alleviate symptoms, 25% of the women are in that optimal zone, but 25% have got too much and 50% have got too little. So we tweak it. We don't even have to test them again because we've gotten so close that a tweak will carry them a year easily.
Okay, so a little bit of a different topic, but because my show, we talk a lot about maintaining and losing weight, a big deal is women just are constantly saying, well, you just can't lose weight after menopause. It's just too hard. Well, I'm in perimenopause, so it's just too hard to lose weight. And I work with them on the thoughts on that because that's just not helpful. Like, of course, you're not going to lose weight if you're thinking I'm not going to lose weight. But what are the real hormonal effects of perimenopause and menopause on weight loss, weight maintenance, those kinds of things? And how does the bioidentical hormone affect that?
Well, you're naming one of the most common complaints of midlife women. They used to be able to maintain healthy weight, and now they can't.
Unexplained weight gain, too, is really frustrating.
Exactly. But it is explainable. It might be unexplained, but it is explainable.
Right. Like they're like, I haven't changed my eating habits
That's
or,
right. That's right.
all those kinds of things.
And I'm exercising like a banshee, and I'm doing better than I ever have in the gym, and I'm still gaining weight. And here's the reason. Hormones are the most powerful biochemicals in our body, and they affect such things as energy metabolism. When you eat food, you eventually convert it to energy and heat. That's called metabolism. Well, metabolism in young people is red hot. But if we measure the metabolism of most human beings as they grow older, that metabolism declines. And instead of burning off those calories, you deposit those calories in the form of fat because you don't have the firepower to burn them off anymore.
Okay, I'm going to interrupt for a second, and I just have a quick question on that. Another thing that I have heard and admittedly taught is part of the reason for that is the sarcopenia that's happening because we have less muscle. Is that a contributing factor or not? Like what causes the metabolism?
Indirectly, I'd say there's more direct.
Okay.
There's more direct. Like, for example, and I'm going to take you on a little journey here. If a woman wants to know if she's fertile because she's having trouble getting pregnant, one of the things she can do is a daily temperature to determine whether or not she's ovulating. And if she's ovulating, that temperature is going to go up mid-month. Why does it go up? Why do you get warmer mid-month if you ovulate? If you don't ovulate, that temperature does not go up. You don't get warmer. You get warmer because your metabolism increased. And the principal hormone that relates to the rate at which you burn, the rate at which you produce energy, is thyroid hormone. Well, midlife thyroid declines are really epidemic. And every functional medicine doctor knows it and is trained in it. But the reason the thyroid hormone starts functioning better mid-cycle is because of a hormone called progesterone. If a woman ovulates, she puts out a huge amount of progesterone mid-cycle, 100 times more than progesterone than she has estrogen. And that progesterone has so many effects, and one of them is it helps thyroid hormone work better in thyroid receptor sites. So her metabolism goes up if she ovulates and produces that huge amount of progesterone. So she gets a temperature increase. She produces more energy and more heat. If she doesn't ovulate, that doesn't happen. The thyroid hormone doesn't get that acceleration. Progesterone, critical for proper metabolism. Metabolism is you eat food and you combine that with oxygen and you produce energy and heat. And them that don't have a vigorous metabolism, they gain weight.
Okay.
They're storing the calories rather than burning them. So that's progesterone's relationship. Estrogen is so energizing, so much so that when you look at the Olympics and you see women athletes who are doing all kinds of phenomenal, crazy, phenomenal skills, very few of those women are menstruating.
At all or at the event?
At all.
Oh.
At all.
Yeah.
Because they've forced their bodies into these really high level output production states. And in order to do that, they need every hormone they got going. So they not only use adrenaline and cortisol, which are so energizing, and thyroid, which is so energizing. Estrogen is energizing. Estrogen energizes metabolism. So instead of the estrogen going down the female pathway, it goes down the Olympics training schedule pathway.
Mm.
And she stops menstruating because she's recruiting and diverting her estrogen into those needs, the fight or flight stuff.
And not menstruating is a whole other, that's a whole other problem in and of itself.
But that's another reason when your hormones decline, you're not producing enough energy because estrogen matters, testosterone matters. And that gets around to your question around testosterone. You're less motivated, but mainly it's also an energizing hormone as well. And when that starts to decline, you can put on weight for low testosterone reasons. So thyroid, estrogen, progesterone, testosterone, these are crucial for an active, vital, high-firing output metabolism that burns your food and converts it to energy and heat rather than stores your food, which you do not want to happen. So midlife, there's a lot of things that coalesce. There's other things that really matter too. We tend to get insulin resistance, and that's a whole other subject. And there's no better recipe for putting on weight than low hormones and insulin resistance. So there's a lot of things that coalesce. It's not a simple thing, but what do? You improve the insulin resistance through diet and other tools that we have, and you replenish the hormones because they really matter.
Yeah.
And you're not going to get that normal metabolism, decent metabolism without it.
All right. Well, I think that we have a lot to think about here, and listeners need to really advocate for themselves. And if they don't have a doctor that's willing to prescribe these bioidentical hormones, is to seek one out. Sounds like we've got some language available to use in your downloadable book that we can use to talk to our medical professionals about that. This is going to be a compounding pharmacy thing. Is that correct?
Well, that's the best of the best of the best. There's all kinds of hormones that are being offered out there, but compounders can individualize for an individual woman. Like you just can't do what's commercially available. So compounding is the best.
One idea might be to go, if you're just not sure who to go to for a practitioner, find a local compounding pharmacy, go in there and ask who is prescribing.
Bingo, Lisa. Bingo, 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 bingo. They know who's prescribing. And there are 9,000 of them in the United States, compounding pharmacists. They know who's prescribing, and even more than that, they know who's doing a really good job.
Yeah.
Because of the quality of prescriptions that they're getting. So that's one of the best resources that you can imagine. We also, I spent 80, 90% of my professional career training and mentoring physicians and nurse practitioners to become expert at this. So you can contact us. And another great advantage about this time is a woman does not need to see a nurse practitioner or a physician in person. For some things, yes.
Yeah.
But for menopause, no. So that means you got access to your whole state.
Right. Yeah.
So anyone who's got a license to prescribe in your state that's taken on specializing in women, so you can do the whole thing by telemedicine. There's a testosterone exception where you have to see them once in person.
Okay.
And there's more and more people getting trained. We're training people every day. We do weekly grand rounds. We've got a lot of people we've trained. So you might check in with us as well.
Okay.
But what you mentioned, Lisa, that can be a great resource. Go to your local and I like how you said it. You said go in there, talk to them, get them out from behind the glass, because that personal connection, it can mean so much rather than trying to do it on the phone or something like that. I loved how you said that. That's the human way to do it. And they care. These are caring professionals. So they get to see in person. It's going to be all that more meaningful to them.
Yeah. I am going to ask you one other just bonus question, since I did kind of mention this about myself. For those of us on birth control, and I'm well past my childbearing years, I had 4 kids. I'm done with all that. My youngest is 15. So I've had an IUD, a Mirena IUD, for 15 years since my last. Should I get it out? Is it time? How do I know? I'm concerned about when do I get this out and start bioidentical hormones, or do I do it in conjunction with?
Great question. I have a deep regard for IUDs. To me, they're one of the most effective ways of planning when you want to have children that exist. And they're not giving yourself hormones at a young age, which can have some not so wonderful effects, like in the birth control pill.
Mhm.
So I really much prefer it over
The Mirena does have some.
I know. So I was just about to
Okay.
say,
Sorry, go ahead.
I much prefer like a copper IUD or other IUDs that are there.
Yeah.
And there's just no way that anyone can guarantee you that you won't get pregnant unless you have some kind of contraception until you've gone 1 year without a cycle. These are what the gynecologists tell us, and they are correct. You can go 9 months without having a menstrual period and pop an egg out of the blue. As you can already see, your periods are declining. That's not from the Mirena IUD. It's from your natural function. You could leave the Mirena in and also start hormones, no problem.
Oh, okay.
You could have the Mirena replaced with a copper IUD and start the hormones. But it doesn't matter that the Mirena is in there. If you go to a provider who really knows what they're doing, they're going to dial in the optimal amount of progesterone. Well, let's start with estrogen. They're going to help you figure out how to arrive at the optimal amount of estrogen, the optimal amount of testosterone. And yeah, you've got some artificial progesterone in there called progestins. It's in the IUD. So what? You just augment that if you need a little more. You augment it with bioidentical progesterone. So it's very easy to work with a Mirena.
Okay.
And it is not going to stop the ultimate ending of your ovaries. So there'll come a time when, look at this, I haven't had a period for a year. Well, now's the time to take out the Mirena.
It's just so hard to tell because they're so very, very light. So sometimes I'm like, was that a period? I don't know.
Well, that's a natural process. And, the Mirena might be augmenting that. But it doesn't matter. So long as you're having any kind of menstrual bleeding, you're in the range where an ovulation, though not common, could happen.
Yeah.
So birth control is still an issue. I mean, if it was up to me and a family member of mine, and I have a lot of women in my family, I would recommend switching to a copper IUD.
I've also been considering switching to, a vasectomy because I could just maybe not be in charge of the birth control.
Well, that's ideal. Vasectomy is wonderful.
Yeah, I just kind of want to be done with the birth control.
So you nailed it. I mean, that would be the best. I think vasectomy is the best, the healthiest, the safest, and it works.
All right, good. And that way we can just focus on getting the hormones for the woman just dialed in and not have to worry about the birth control. Well, again, thank you so much. Appreciate that extra bonus question that wasn't really part of our topic. A little personal there for me. Sometimes I do ask these personal questions of my guests. I'm like, well, I have you. Let me just ask you this.
Well, there's millions of women who have that same question.
Yeah, Mirenas are pretty common.
Yeah.
So good. Well, again, thanks so much. And we'll put the link to the book in the show notes.
I'd want to say just to add on, the Mirena has no estrogens,
Right.
which is the very reason you're getting those hot flashes.
Yeah.
It has no androgens. It has no testosterone in there. And you're going to love testosterone. I often think it's one of the best things we do for women. Keep them out of nursing homes and diapers.
Yes, please. Let's do that.
Yeah, that's right. Let's have that health span.
Yeah.
Like you described.
All right. Thank you so much for your time and your wisdom and your experience and sharing it. I really, really appreciate it.
You're welcome.
I hope you enjoyed this episode with Dr. Rosensweet. Our recording kind of got cut off at there at the end, but I did thank him, and he was so gracious to come on the podcast and really share his expertise. Grab his book in the show notes and let me know how you're doing with perimenopause and menopause. And if you have any questions related to what we talked about or weight loss in those times, I'd love to help you. Hey, thanks for listening today. If you're ready to get some personalized coaching from me, I'd encourage you to schedule a free strategy session. Visit www.wellwithlisa.as.me, or it's easier just to find that link in the show notes. We'll talk about where you currently are with your weight loss goals, and I'll give you some actionable tools you can start implementing right away. Before you go, make sure you subscribe to the podcast so you can receive new episodes right when they're released. And if you're learning something new and enjoying the podcast, I'd love for you to leave me a 5-star rating and a review. Thanks again for joining me, Lisa Salisbury, in this episode of Eat Well, Think Well, Live Well.